seeing our attendee numbers climb quickly, so I am going to get started. I know we have a lot of material to get through today, and I am anticipating a lot of questions as well, so I'd like to get started. My name is Meg Beyer. I work at ICL in MCTAC, and I'm excited to be kicking off this webinar before passing along to our wonderful state partners this afternoon. I wanted to run through just a few matters of housekeeping before we get started. For those of you who have joined our webinars before, some of this might be repetitive, but I just wanted to make sure that everyone knew how to chat in questions for the Q&A section at the end. If you look to the right-hand side of your screen, there's a chat box. What we request so that all of the panelists joining today are able to see all the questions that come in is that before you chat in your question, you make sure that you select the drop-down arrow and note the all panelists should be sent the questions. This way, all the panelists can see the questions that come in and hopefully get all of them answered. So again, please start early and often throughout the webinar. Feel free to chat in your questions. We have a lot of content to get through, and in the past we've gotten a lot of questions. We do try and answer as many as we can and as many as we're able to on the actual webinar. Also, the slides and the recording of this webinar are going to be posted at mctac.org. And this usually is posted within the time frame of a week after the webinar. So stay tuned to the mctac.org website for the slides and the recording. And again, questions that are not addressed today, as I mentioned, we do get a lot of questions chatted in, which is fantastic, will be revisited during subsequent presentations. The other thing I just wanted to remind everyone, as the webinar today will be recorded and posted on the MCTAC website, is that all the information and timelines are current as of today, which is Thursday, February 11th. So if you're listening to this in the future, as we're going to record this and post this on our website, please keep that information in mind, that all the info and timelines are current as of February 11th, 2016. And with that, I'm just going to do a little intro about MCTAC and CTAC. For those of you who might not be familiar or might be joining us for the first time, CTAC was founded in 2011 as the Children's Technical Assistance Center and expanded in 2012 to offer technical assistance to all Article 31 mental health clinics in New York State. We have since expanded to provide technical assistance for the managed care transition, and we now call ourselves the Community Technical Assistance Center of New York. And as New York State continues to transition and transform to managed care, the MCTAC and CTAC will continue to provide a series of offerings around the state to assist providers in the transformation process and making sure that providers are readying themselves for this transition. Okay. Now, before I pass off to our state colleagues who will be running through the webinar, again, I just want to remind everyone, please do chat in your questions to the chat box on the right-hand side. And if you could be sure to, please select all panelists for the questions to be chatted into. That way we can all see the questions that come in. So with that, I'm going to pass the presenter to our state partners. Okay. So I've just done that. Okay.
All right, thank you. Let's see if our moving the slides works this time.
Yeah.
There we go. So I'm Angela Keller from the Office of Mental Health and the Division of Managed Care. And I, with my colleagues from the Office of Alcoholism and Substance Abuse Services, the Office of Children and Family Services, and the Department of Health, have been working on this design. Many of you have heard us make presentations in the past, and we're just continuing this dialogue across the state of where we're going with children's Medicaid system. We're really excited to continue with part 2 of our 3-part series. In the first part, we had hundreds of attendees, and your questions have really shaped what we're going to present today as outlined on our agenda. So over the next 30 minutes, we're going to talk about the goals and key features of the KIDS design, review some Medicaid basics, give you a little more information than we did in part 1 on the new state plan services and the HCBS benefits, And then we'll close out with MCTAC reviewing some of the offerings that are coming up for technical assistance and have time for questions and answers. And again, your chat box on the right-hand side, if you can please select all panelists and send us your questions throughout the webinar. And you'll hear me say that many times because we would like to hear from you. Hopefully by now you've come to understand the goals associated with the transformation that we've been designing. We will really want to get kids in receipt of Medicaid back on their developmental trajectory. We want to identify needs earlier, maintain kids at home in the community and least restrictive settings, and prevent longer-term need for higher-end services. Ultimately, what we're shooting for is that children and families receive the right services at the right time in the right amount. We do want to emphasize that this design is still very much a work in progress. We are continuing to develop many details and policy decisions related to the design. So again, everything that you'll hear today is current as of this moment, and things will continue to change and evolve as we make decisions. To recap the key features that we reviewed the last time and the timeframes for some aspects of the design, let's begin. So the first thing that will take place as part of this transformation will be in September of 2016, when we expand access to care management for children with chronic conditions under the Health Home program. Health Home is a voluntary program, and for those children and their families who are ineligible or who opt out of Health Home and later become eligible for the aligned array of home and community-based services, care management will be provided in a different way, still under discussion. In January of 2017, we hope to create and implement the new state plan services. Also in January of 2017, in New York City and Long Island, we will transition the existing children's behavioral health benefits from fee-for-service to managed care. We also will provide a greater access to the aligned array of home and community-based services and begin to shift the voluntary foster care per diem population to managed care. The same three activities in the bottom three bullets will occur in July of 2017 for the rest of the state. I'd like to briefly go through some Medicaid basics and some key points about New York State's system. For some of you, this is going to be very familiar, so please bear with me through the next few slides. We just want to make sure that people understand the nuances between Medicaid eligibility and the different payment systems and where services and benefits are available today and will become available in the future. So what makes a child eligible for Medicaid today? This is a very simplified list of circumstances that could make a child eligible for Medicaid coverage, not a complete list or intended to be. It's just to give you a flavor of some of the things that could make a child eligible. And as you all know, there's different doors to Medicaid eligibility. A child and their family could come to the New York State of Health Exchange, could go to their local Department of Social Services or HRA in New York City, or through New York Managed Care, they could access or apply for Medicaid. So it could be based on income, disability diagnosis or criteria, spending down of a required amount in medical expenses, and then sometimes for children that are adopted, they may be eligible to continue their Medicaid coverage from foster care. Once enrolled in Medicaid, a child has access to all the Medicaid benefits for which they're eligible. The benefits would fall under one of two payment systems. Typically, when a child and even a family or an individual is first enrolled in Medicaid after they've completed their application and it's been determined that they meet the eligibility requirements, they're enrolled in the fee-for-service delivery system. Then a determination is made whether they are an excluded or included population from Medicaid managed care. If they are not excluded, they would then be enrolled in Medicaid managed care, and there's a process where the family is presented with a choice of plans that really best meet their needs and potentially have already the specialists or doctors that they're receiving care from in the plan's network. So Medicaid Managed Care System is an organization that's authorized by New York State Department of Health. They receive a monthly premium from New York State for the enrolled individuals in their plan, and they manage everyone's care within a specific comprehensive benefit package. The plan assumes risk, they provide care management, and they apply utilization management methods for each of their members. And there are really a lot of opportunities and techniques that are used in managed care that provide us with the opportunity to have an efficient and well-used system that's focused on outcomes for kids. So when providers in that plan's network provide a service to a child, that provider in turn bills the plan, and the plan pays the funds from the premium. In contrast to the fee-for-service delivery system, a provider is authorized by New York State to deliver a Medicaid service. When they deliver that service to enrolled and eligible individual, that provider would bill Medicaid through the eMedNY New York billing system, and then New York State directly pays that provider. So those are the differences between those two systems. So today, some examples of Medicaid services that Medicaid Managed Care pays for children include physical health services such as visits to the pediatrician, vaccinations, screening, dental care services, some behavioral and physical health inpatient care, so if a child goes into the hospital for any reason, and some mental health outpatient clinic services, particularly for those clinics that serve both children and adults. Again, this is a very brief outline of what Medicaid Managed Care pays for today and is not intended to be an exhaustive list. There are many Medicaid services that are managed by the Medicaid Managed Care plans at this point in New York State, some of which I just went through on the previous slide. Some services that children access today are available to Medicaid-eligible children that are paid right now in the fee-for-service system. While available to a child with Medicaid, these services are not managed or paid for by the Medicaid Managed Care plans at this time. All the services on the slide that is currently on the screen will transition to Medicaid Managed Care beginning in 2017. Additional benefits covered under fee-for-service Medicaid are available to children regardless of Medicaid Managed Care enrollment. Currently, kids would access services using their Medicaid card when they present for services. There are, however, some Medicaid-eligible populations that are excluded from enrolling in Medicaid Managed Care today. So, for example, children with third-party health insurance, so they have a parent who's employed and that employer offers health insurance coverage or they get coverage through the exchange, they would not be eligible for enrollment into Medicaid Managed Care, but could still be eligible for Medicaid and the benefits under Medicaid. And as you see, there are other examples on this screen: children who are duly eligible for Medicaid and Medicare, children placed in voluntary foster care homes, youth placed in OCFS-operated juvenile justice facilities, children who are enrolled in Child Health Plus, children who are part of Native American tribes, and eligible individuals served by the Office for People with Developmental Disabilities because their managed care initiative is a separate process. So again, some kids could be eligible for Medicaid and the benefits and services for which they qualify, but not be enrolled in Medicaid Managed Care. All their eligible services would be paid through the Medicaid fee-for-service system directly by New York State. As we covered in Part 1 on January 27th, all Medicaid coverage services are available through the comprehensive Medicaid benefit package in New York State, whether paid for Medicaid Managed Care plan or by the fee-for-service payment system. For children today, the system includes some services managed and paid by Medicaid Managed Care, such as hospital inpatient care for an appendicitis attack, but the majority of specialty behavioral health services are carved out in the fee-for-service payment system. As you see in the blue box, this includes children's behavioral health services, a limited array of HCBS services depending on waiver program available only to waiver-eligible children through the fee-for-service system, and care coordination through OMH, TCM, and the Children's Waiver Programs. As we move to full managed care implementation represented in the green box, the current Medicaid behavioral health services, health home care coordination for children, 6 new Medicaid state plan services, and the home and community-based benefits will move under Medicaid managed care for those children who have Medicaid and who can also enroll in Medicaid managed care. The managed care plans will pay for any services authorized and used by their enrolled members out of the monthly managed care premium. For children, again, who are eligible for Medicaid but excluded from enrolling in Medicaid managed care, they may receive the comprehensive Medicaid benefits for which they are eligible and in the fee-for-service payment system. New York State would pay those providers for any services authorized and delivered to those eligible children. Also, for the first time with this transition, children in foster care that are cared for in voluntary foster care agencies in the community and categorically eligible for Medicaid will have their services paid for by Medicaid managed care plans. This transition is similar to the transition that occurred in 2013 for community-based foster care children. So let's stop and look at a specific example to demonstrate what we've just reviewed. So here is Michael. Michael lives with his mother and 2 siblings. He's eligible for Medicaid due to his family income, and he is also eligible to be enrolled in a Medicaid managed care plan. Today, he has access to the comprehensive Medicaid benefits for which he qualifies. His Medicaid services are paid through the Medicaid managed care system and the Medicaid fee-for-service system. So we've broken those out into 2 circles. The circle on the top is what the Medicaid managed care plan would provide. So for example, they would pay for his dental checkup, his pediatrician visits, his medications, and any other services contained under Medicaid managed care. He also is receiving additional Medicaid services that are carved out of Medicaid managed care today. So for example, he's receiving HCBS services through the OMH SED waiver and services in an OMH designated SED clinic that is not yet carved into Medicaid managed care. In the future, all of his services would need to be managed and paid for within managed care. And we put some examples in the circle on the right, such as his dental checkup, vaccinations, testing and treatment for strep throat, services in an OMH designated SED clinic, the new psychosocial rehab service in the state plan, health home care coordination, HCBS skill building, and HCBS respite. So all of it will then be centralized within the plan and paid by the plan in this example. So hopefully the little bit of time that we spent on Medicaid Basics, and once these slides are posted, I really encourage you to go back and reread. The distinction between who pays and where kids can access services is really the distinction here. Once eligible for Medicaid, you're eligible for all services in the comprehensive benefit. But where it's paid for differs today, and then we're moving things towards managed care. So we'll talk a little bit more in depth today about the new state Medicaid plan services and other changes that are coming in 2017. We reviewed the 6 new state plan services in Part 1 webinar, which are listed in the first bullet on this slide. Other work that's in progress to move us towards the January 2017 implementation include work with our state interagency partners on the final details of the state plan amendment application, in addition to developing payment rates for the 6 new services. We still hope to submit our application to CMS in April. We had shared a draft application and had some introductory phone calls with CMS last summer that were very positive about our SPA. Once the application is received, we'll begin that negotiation process with CMS to move towards eventual approval of the services. The good news is that funding has been included in the proposed state plan budget that's currently under consideration for the next fiscal year. And that's detailed in the third bullet on this slide, that it includes support for these new 6 state plan services to begin in 2017, which is the last quarter of the 16-17 budget. And then an additional $30 million has been earmarked for the 2017-18 year to continue to grow the 6 new state plan services. We also hope to release a final draft of the state plan provider manual this month so that providers and plans really will understand what will be required to deliver one or more of these new services. But again, as everything with this design, anything in that provider manual is subject to change once we begin speaking with CMS. And we will also be providing a lot more detail at the in-person sessions that we'll be holding in March and April around the state, where we'll give more detail on the 6 services and our aim, and certainly more detail on the implementation. In Part 1 webinar, many of you asked how agencies would become a provider of the new 6 state plan services, so we want to review where we are right now. We anticipate that there will be an application and designation process of some sort, probably late spring or after. What we are looking at is the providers that will be eligible to provide these services and be designated would need to hold specific types of licenses, certification, or designation from one of the 4 agencies, and also have experience serving children. We will, at the point that that process opens, be informing everybody what's involved, what you need to do, what are the timelines, and technical assistance will be given, certainly to those that are not already Medicaid providers, but those that are already have experience with Medicaid. We'll provide guidance on MMIS provider enrollment for these services and every other step of the way as we get to it. Also in tandem with that work, approximately 6 months prior to launch, so that's around June, July, MCTAC will begin to offer some very specific service training around these SPA services. So as I said, we hope at the end of the month to share the draft SPA provider manual. This slide just details what's contained in that, and that will give you some sense of what we're expecting, what are the medical necessity criteria that are required for children to receive these services, what are the agency supervisor and practitioner qualifications, training requirements, et cetera. There will also be a billing manual that will be developed as we're further in the process with CMS, and that'll be released statewide separate from the provider manual. In trying to keep this brief and allowing for time for questions, and if you haven't already, please go to the right side of your screen, select all panelists, and continue to send us your chat questions so that we can get to those at the end. Let's go into a little bit of detail on the home and community-based benefits. They will also be covered in the in-person sessions that will begin around the state in March. In order to implement the home and community-based benefits, New York State needs to file an 1115 application with CMS and complete a number of other tasks. So we are progressing in developing the application. It is still very much in draft, and there are still a number of critical policy discussions and decisions there that are in process. We will need to develop a request for qualification for the Medicaid managed care plans, and the RFQ and the documents that then come in as a result of that will allow us to qualify plans to manage all of these benefits, which we've been talking about. We will also have an HCBS provider manual, which is just beginning under development. the HCBS payment rates are under development, and we will need to also work on revisions to the managed care model contract to detail specific implementation requirements for the Medicaid managed care plans to follow as they begin to manage all these benefits for children. This should look familiar to most of you. We reviewed this slide in part 1, and it has also been part of many other slide decks that we've been doing in the past year. So this indicates the services that we are proposing under the 1115 amendment. The 1115 amendment would give New York State the authority to include these services in its comprehensive benefit package and be paid for through both the Medicaid managed care system and the fee-for-service payment system. And for those of you familiar with the 1915C children's waivers, this is an alignment of services across those waivers that most folks are on the phone, I assume, are probably familiar with. So that's the OCFS Bridges to Health waivers, the DOH Care at Home 1 and 2 waivers, and then OMH's SED waiver. The current children's HCBS providers within the 1915C waivers will be grandfathered and designated to provide HCBS within the managed care delivery system. We anticipate that designation will occur through a letter, and then there will be some sort of required attestation and agreement that will need to come back from the provider affirming that they are willing to provide that HCBS service. So, for example, if you're a community provider that's designated right now to provide planned respite through the OCFS Bridges to Health waiver, you would be grandfathered to do so as we transition to Medicaid managed care. If there are children's providers out there that are designated right now or in the process of designation to provide the adult HCBS benefits to HARP enrollees, we would anticipate grandfathering those children's providers as well. And if the existing grandfathered and soon-to-be designated children's providers wish to provide other HCBS services, they will need to apply for additional designation with an application process. Once that is all done, that list of providers will be given to the Medicaid managed care plans, and at that point, real discussions can occur in terms of contracting, and as we get closer to that point, certainly there will be a lot of information and technical assistance provided to help everyone get ready for that. But we know that the existing 1915C waivers that serve about 8,000 kids a year does not have all the capacity we're going to need in the future. So we'll need to grow more capacity for the HCBS providers, and we will have an application process for new providers that'll be very similar to the one that was undertaken on the adult design. There will be an application process. Again, once designated, that list of providers will be given to the Medicaid managed care plans. For those that are not Medicaid providers but have been designated, we will provide technical assistance on how to facilitate that. So at this point, I'm going to turn it back to the MCTAC team to talk about upcoming technical assistance.
Wonderful. So Angela, thank you so much, Angela, for passing me the presenter controls. So again, my name is Meg Beyer, and I'm just going to talk through the next few slides, which kind of talk about upcoming offerings around technical assistance. So as you know, today is part 2 of a 3-part series of webinar offerings. Our third and final part of this webinar series is going to be on the topic of building capacity and preparing for the changes ahead. It will be Thursday, February 25th, and it will be held from 12 to 1 p.m. I would encourage everyone to register if you have not already. I know our registration for these webinars has been significant, so I just want to encourage everyone to register early. And again, this webinar is going to be around identifying areas that providers will have to build the knowledge and capacity to prepare. A reminder that all slides and recordings from this webinar series will be available via mictac.org. Questions can be sent in advance to our general MCTAC email address, which is on the slide. It's mictac.info@nyu.edu. Just a reminder, though, for those on the on the webinar presently, if you do have questions that you'd like us to try and answer today, please go to your chat box and select all panelists and chat your questions in that way. We'll be getting to that as soon as I wrap up upcoming offerings. Okay. And as Angela has mentioned, we are going to be having a series of in-person, in-depth transformation updates presented by OMH, OASIS, DOH, and OCFS regarding the Children's Leadership Team and transition for the children's system. So those events, as you can see, are on our slide right now. The one thing that I want to note is that the New York City event on the 22nd will not have both a morning and afternoon offering. It will just have a morning offering. If you want more information on this, I would encourage you to visit our website at mictac.org, and really technical assistance will be offered for SPA, HCBS, and the managed care transition, including high-level topic introductions and in-depth implementation guidance. Okay. And again, just to remind everyone, the first part of this webinar series, which was held a week or so ago, maybe a little bit longer, is on the recordings, and the slides are already posted to the MCTAC website. The slides from today, in fact, are posted on the MCTAC website. And as soon as we can upload the recording from today, we'll do so as well. Okay, so here are some preliminary resources and information we wanted to make sure everyone on today's webinar knew about. So these are existing tools that we have compiled, and essentially these grew from the transition of the adult managed care, the transition to managed care for the adult system. There's a glossary, there's a top acronyms guide, there's a managed care language guide, there's a matrix, which is a tool that we compiled around all the different managed care organizations. Contact information is all contained on there. There's an FAQ. I would really just encourage everyone to visit the MCTAC website and look at resources and tools. There's a lot of information there, and again, there is more to come. And also, just to stay current to the New York State DOH website, we included the link there as well, just so for those viewing these slides in the future, you're able to click there and look at this. Okay. So next, we are going to start answering questions. Before we do so, I'm just going to make sure all of our panelists have all the questions that have come in so far. I do want to encourage everyone to continue to chat in your questions as we start to answer these. So with that, I think I'm going to have to email these questions, so I'm going to do that quickly. All right, and then, okay.
This is Angela from OMH. We can begin to take a few of the questions that we can see while we're waiting for that email to come to us with the questions. So one of the questions is, could we say more about why we believe the transition from fee-for-service to managed care will be better for integrated behavioral health and physical health? I think one important thing, if you look back at the slide with our example for Michael, is that there are two payment systems that are managing or paying for different sets of benefits. And there's no one entity that's really coordinating and integrating all of that. So it really leads, in more cases not, for services to be disjointed and uncoordinated. And managed care as an industry has many tools available to it, or has developed many tools that really allow for focus on outcomes and not focus on volume of service. And fee-for-service encourages individual billing for numbers of services in order to maintain revenue, in essence, as opposed to what is it that we're really trying to do for a child and family, and managed care has many of those tools. So by putting all of that together, it does move us towards integrating behavioral and physical health. Okay, so one of the questions is whether children in OCFS agency-operated boarding homes are eligible for Medicaid managed care, and I'll turn that over to Mimi Weber from OCFS.
Thanks, Angela. Children that are placed in voluntary agencies within an agency-operated boarding home are currently not eligible for Medicaid managed care. That group of kids is part of the transition that we expect to occur in 2017.
Okay. Another question is, there was some misunderstanding from some of what we presented. Currently, children served in an OMH-designated SED clinic but have not been diagnosed with SED, are they carved out of Medicaid managed care or not? And Donna Bradbury from the Office of Mental Health will take this question.
Sure, thanks, Angela. So in the current system, clinics who are designated as children's specialty clinics for kids who are deemed to be seriously emotionally disturbed, those children are carved out of Medicaid managed care. So those clinics can bill fee-for-service for those children. Currently, in those same clinics, if a child is not seriously emotionally disturbed but is nonetheless being served by that clinic and has Medicaid managed care, then Medicaid managed care is the payer, not fee-for-service. I hope that answers the question. I think it was Heather that asked that question.
The other question is, will OMH community residents for children be treated the same as an RTF? Just one thing of note is that it is likely, and we did not have community residences for children as being one of those services that will transition to managed care immediately in 2017. That will come at a later point due to some of the details that are under the CMS HCBS final rule and how they view certain settings and where children can receive home and community-based services. So there's much more to come on that.
Can I just ask the panelists to mute themselves? We're getting a little feedback. Thank you.
So what does this mean for individuals with the 95 carve-out? So those are children, 95 is the Medicaid district that OPWDD has available for their system and children who and adults that are served in their system. So if a child is in District 95, they would not be eligible for these services. And there will be a separate process for the OPW managed care development that I'm sure OPW will continue to educate everyone about.
Angela, and if I could, this is Mimi Weber from OCFS. If I could just add to that, we certainly recognize that children who are in the care and custody of a local Department of Social Services and placed in foster care are not eligible for OPWDD services. So I just want to clarify that the system that we are designing today will be able to accommodate children in foster care who've been determined to have a developmental disability. That is a nuance that's really important to a small cohort of kids, but and is being accommodated in the design.
Okay. So one of the questions, as waiver services move into managed care, will there still remain a cap on the dollars that can be spent on the comparative needs services per child? For example, in Bridges to Health, there's a $51,600 cap for all services for children in Bridges to Health.
Hi, again, this is Mimi Weber. And so the state team is taking a real close look at developing, in essence, what we're calling service utilization thresholds. So we will be moving away from a fiscal cap, and we'll be looking more at developing, in essence, service utilization thresholds. Those thresholds have not yet been determined, but certainly we're spending a lot of time reviewing current utilization of waiver services, which will absolutely inform those thresholds that are under development.
Okay. Another question is, will a current children's HCBS provider directly or subcontractor need to reapply? I'm assuming that this question is related to current HCBS, children's HCBS providers and grandfathering, so to speak. So those that are currently providing specific HCBS services, we will send out a letter and indicating that you have been grandfathered to be an HCBS provider as we move to the managed care transition in 2017. So, for example, Bridges to Health provider that provides respite will get a letter saying you will be designated as an HCBS provider in the managed care design for respite in the future. And there will be a process that there will be an attestation that, yes, they agree to abide by all the requirements, do want to provide that service as we move to managed care, and send something back to the state. Once that process is completed, then, you know, we'll forward that list to the managed care plans to begin that contracting process. So grandfathered providers will only need to apply for additional HCBS designation if there are other services, HCBS services that they don't currently provide that they wish to provide in the future. If an agency is approved for adult HCBS, are they automatically approved for children's HCBS? What we are anticipating is that if an agency, a children's agency whose business it is to provide services for children, has been designated as an adult HCBS provider, we would also designate them as a children's HCBS provider. But if it is an adult-only, adult designated HCBS provider, that's still yet to be determined. Questions on timelines. When do we expect the RFQ will be released? I would not anticipate until probably late spring or thereafter. We had indicated at presentation last year that we had hoped it would be in the first quarter of this year, and I am confirming that the RFQ will not be released by the end of the first quarter of this calendar year. Is there a tentative date in 2017 that managed care will start managing? Our target date is still January of 2017 for Long Island and New York City, and July 2017 for the rest of the state.
There's a question about what's the difference between habilitative skill building and habilitation. Some of the words are important as we speak to our CMS partners, but in essence, habilitation skill building looks an awful lot like skill building as we provided today within the B2H and the OMH waiver. Habilitation services tend to be centered around activities of daily living, and so we would expect kids who have been determined eligible for these services based upon a developmental disability to access habilitation services to a greater degree. There are a couple of questions around, I believe the questions are somewhat awkwardly worded, but I think folks are struggling a little bit with the CSE, the Committee on Special Education, children that are residentially placed. This came up at our first webinar, and we certainly recognize that there's a great deal of anxiety about how CSE residentially placed children will be handled through the transition. It's important to note that it's a relatively small population. As of today, there are about 800 children across the state of New York that are CSE residentially placed with voluntary foster care agencies. About half of that population is already enrolled in Medicaid. And so for that cohort of kids, we will treat them just like we would treat any other child who's placed at an OCFS licensed facility. It's more challenging when we start thinking about the cohort of CSE residentially placed children who are not Medicaid eligible, and we're working with our federal partners to figure out a process to ensure that services are appropriately provided to that population. And of course, that the providers of those services are appropriately reimbursed. So we ask you to stay tuned for that conversation as it continues to unfold.
Another question that came up is, who can deliver the 6 new state plan services, and does that provider or does it need to be through a licensed clinic or day treatment program? What we've indicated is that, and there will be much more detail to come in the coming months, but that the providers of the 6 new state plan services need to be licensed, certified, or designated by one of the 4 state agencies that are participating in this design. So that could mean, for example, that an agency that has a licensed clinic or has day treatment or an RTF, or an agency that's a voluntary foster care program, or an OASF outpatient clinic, or provide services to the care at home medically fragile population. Any agency that does that would then be eligible to deliver one of the 6 state plan services. Again, there will be an application process. When the provider manual comes out, there will be a lot more detail about what's required. And merely because an agency has a day treatment program doesn't necessarily equate that you might want to or be qualified to provide all 6 of the new state plan services. Okay. We're still looking through. There are so many questions that you all are have sent in, trying to find ones that are not duplicative of what we have already answered. When do we expect the billing manual to be completed? I would guess later this year. That is a step that once we're a little bit closer to getting CMS's reaction, that we would certainly be able to develop that and put that together.
Angela, someone else is asking the question, can an OPWDD agency be able to apply to become an HCBS provider agency? And the answer to that is we would absolutely encourage that to happen. We are all a little concerned about the capacity to meet all of the needs of kids that we anticipate that will come through the HCBS door. So we would encourage folks to seek designation as an HCBS provider.
And again, with any of the SPA services, if an agency feels that they are qualified to provide them, once we have outlined what that application process is, certainly providers are welcome to apply. Another question is, has it been determined if health homes will be the enrollment and eligibility screening vehicle for the HCBS services? And is additional children's health home capacity being planned for? Certainly, children in health homes who are receiving care coordination, as they have that relationship with their care manager and begin to identify needs through the completion of a full CANS New York assessment, SPA services and HCBS services, in addition to informal supports from the community, would be incorporated into the single plan of care within the health home. The health home care coordinator will have a role in eligibility and looking at whether a child needs and qualifies for HCBS, and that will be spelled out in the coming months. Okay, other questions? Take that one.
Sure. A question is being posed. Children in foster care in Bridges to Health will not be eligible for health home enrollment in September of 2016. That is a correct statement. The question is, with this program changing in January 2017, who will be doing care coordination for these children at that point? Should they then be enrolled in a health home? The answer to that is yes. But we are still working through here at the state level and certainly with our CMS partners what that transition will look like. But it is the plan that children who are currently being served in all of the 1915C waivers, B2H, the OMH waiver, as well as the care at home waivers, that their Medicaid care management will transition into a health home environment. There's another question, when will foster care agencies find out when the residual per diem starts and the dollar value of the residual? That's a great question, and there's a tremendous amount of work going on between OCFS and the Department of Health to figure out the components of the residual per diem and what the value of that will be. So once again, stay tuned. Another question has come through from our friends down at Little Flower in Long Island. Can HCBS services be provided to kids in an RTC come 2017? An RTC is an acronym. It's a residential treatment center that's licensed by OCFS. Given the 2014 HCBS ruling around settings, we don't think that an RTC would be an eligible setting for HCBS services. So Michelle, the short answer to your question is no, we don't think HCBS services can be provided to kids in an RTC environment. RTCs do not contain all of the characteristics of a home and community-based settings that CMS has put forth.
And this is Angela Keller, and I would also add that the same would apply for an OMH RTF, that CMS would not consider that setting to be one in which home and community-based services would be allowed to be delivered. So any child that resides in an RTC and an RTF would not be eligible for the home and community-based services we've been talking about, but certainly would be eligible for any state plan services, including the 6 new services.
And I think just like they did on the adult side, as we start designating providers, we'll be looking into more detail about where those services will be provided, so more clarity would we anticipate will be forthcoming.
Okay. So another question is that we just said that January 2017 is when managed care will kick off in New York City, and the person indicated that they thought September 2016 is when it would be rolled out. So there's a little confusion. So let me review that again. September 2016 is when children will begin to be enrolled in health homes. January of 2017 is when we anticipate the new state plan services will be implemented. We will also begin to move the existing behavioral health services into managed care. We will also have available the expanded array of home and community-based services available and managed through Medicaid managed care. The foster care population will transition to managed care. And a number of the other transitions we've talked about. So in January of 2017, all of those things start to occur for New York City and Long Island. July of 2017 is when the Medicaid managed care transition occurs for the rest of the state. And again, when these slides are posted, which I believe they already are, to the MCTAC website, those timelines are there, and I really encourage you to print out. I believe it's the third or fourth slide. Tack it on your bulletin board so that it's clear what comes first. And we know that this is confusing. There are many details, many phases to the children's design, and we're trying to not have it all occur at the same time. Here's a great question, and this is probably the last one that we can take. What is included in the other licensed practitioner service? Great question, and we actually have an answer now. So other licensed practitioner is an authority that allows us to reimburse through Medicaid a defined group of licensed practitioners. So in our case, under the Medicaid benefits available in the early periodic screening, diagnostic, and treatment services, otherwise known as EPSDT, we are including licensed clinical social workers, licensed master social workers, licensed mental health counselors, licensed marriage family counselors, and licensed psychoanalysts as being able to go out in the community and provide services that they are allowed to under their state license and be paid by Medicaid. So other licensed practitioner is a reimbursement authority to allow providers to do what they are allowed to do under state law out in the community. So I think that was we've arrived at 1 o'clock. Does MCTAC want to close us out? And we really appreciate everybody's questions, and there's many we didn't get to, and we'll continue answering questions in the coming months.
Okay. Well, thank you, Angela, and thank you, everyone who joined for the call today, all of our state partners who are jumping in for all of the questions that came in. Thank you to everyone for chatting in your questions. We will work to kind of build a comprehensive question list to try and get these answered. We have a ton of questions that came in on today's webinar. So again, please feel free to visit the MCTAC website for more information, for all the recordings and slides, and thank you for joining us today.